complete three small questions before we get started. Thank you so much for doing that for us. For those of you that don't know, this is the first one in a series of 4 that will end on September 26th with a virtual rock concert called The Rock of Faith. Many of you are familiar with The Rock of Faith, which is a concert that I created 10 years ago to tell the story of addiction. And while typically we send a donation from the proceeds of this concert to a sober house in the community that is helping people recover from addiction, we had to rethink how we could help the community because due to COVID-19, we were unable to have our annual concert in the sanctuary. So we had to look at what we could do to help the community. Well, that is just when God took over and brought us a plan that we just couldn't refuse. This year, my church, First Baptist Church of Greater Cleveland, received a grant to provide opioid education for the community. Well, that sounded like a pretty good partnership to me. So together with a group of very dedicated individuals, we created the Rock of Faith Community Conversations. This is a 4-part series to bring to you the community education and awareness about opioid addiction and recovery from opioid use disorder. This series will air for approximately 1 hour tonight, next week on September 5th. Then on Saturday, September 12th, we will not have an evening presentation, but we will have the Project Dawn van in the parking lot from 10 to 12 in the morning during our food distribution for people to pick up Narcan kits. And we'll talk about that later and how important that is for opioid use disorder. Then the following week, on the 19th, we will have another evening presentation, they're all starting at 7 o'clock. And then on the 26th of September, we will end the entire series with the virtual Rock of Faith, which will take you on a journey through addiction into recovery. You can find all this information on our church website, firstbaptistcleveland.org. We hope that you put this on your calendars and get your watch parties ready to go. But now, in the meantime, we have 3 wonderful programs to bring you. Tonight, we are very fortunate to have 2 doctors that have worked in the field of addiction for a very long time. They have seen this opiate crisis take off, killing people they love, as well as thousands of people in our community. They both were happy to join me tonight on this stage to bring you their knowledge and their experience and give you an opportunity to ask questions. So let me introduce Dr. Ted Parran, who is a 1982 graduate of Case Western Reserve University School of Medicine. He completed his residency in internal medicine at Baltimore Children's Hospital of Johns Hopkins University School of Medicine. Dr. Parran was selected to be the medical chief resident for 1 year following his residency and received the Outstanding Faculty Teacher Award from the Department of Medicine in 1987. In 1988, he returned to Cleveland to join Dr. Christopher Adelman in his addiction medicine practice. He returned to Case Western Reserve School of Medicine and is an associate clinical professor of internal medicine. Dr. Parran is certified by the American Society on Addiction Medicine, and his group practice provides medical directorship services to several substance abuse treatment programs and consult services in Cleveland, including Stella, St. Vincent Charity, Rosary Hall, and the Cleveland Treatment Center, and the Salvation Army Harbor Light, to name a few. He is the co-director of the Introduction to Clinical Medicine for the first 2 years of medical school curriculum and the medical director of the program in continuing medical education, all at Case Western Reserve School of Medicine. Also with us here tonight is Dr. James Psarras, who is also a graduate of Case Western Reserve University as a chemistry major. He then went on to medical school at Ohio State University. He returned to Cleveland to complete his residency at University Hospitals Cleveland. He has since worked at several inpatient psychiatric hospitals, including St. Luke's, St. Vincent Charity, and currently Windsor Laurelwood, focusing on dual diagnosis and substance use disorders. He has been the interim chief medical officer at all 3 of these hospitals, and at the same time maintained a private practice for over 40 years, focusing on anxiety disorders, personality disorders, and general psychiatric issues. Most important, Dr. Psarras and his wife Elaine founded Andy's Foundation in 2005 after the accidental opioid overdose of their son Andrew. We are blessed to have them both here with us tonight, and now I'm going to get out of the way and let them talk to you.
Dear. Sorry about that. Thank you very much, Carole, for that kind introduction, and I really appreciate the opportunity to be here today to speak with you all as a faith community about the subject of opiate use disorder. It is a tragedy in our community. It's a tragedy in our families. It's a tragedy in our nation, and a tragedy that we've finally began to get our arms around and to begin to more successfully grapple with. And so what I'm here to talk with you about this evening is a brief overview of what is opiate use disorder, what is opiate addiction, as many of us would call it, in our living rooms, in our kitchens, in hushed conversations. What is it? Why does it happen? How can you recognize it? What does it do to people? And most importantly, what can we do about it as individuals, as families, and as communities? When people ask me, what is opiate addiction? I think it's most important to first start with the question of what is addiction in general. Because addiction in general is an overarching disease that has alcohol use disorder or alcoholism underneath the umbrella of the disease of addiction, opiate addiction or opiate use disorder, stimulant addiction or stimulant use disorder like cocaine or methamphetamine addiction, and marijuana addiction or marijuana use disorder. All of those separate substances, alcohol, opiates, stimulants like cocaine or methamphetamine, and marijuana, all of those are subsets of the overarching disease of what we call addictive disease. Addiction affects somewhere between 1 in 8 and 1 in 10 American adults. So if you think about it, if on average there's 2 adults living in each household on your street, and if addiction affects between 1 in 8 and 1 in 10 adults, then between 1 out of 4 and 1 out of 5 houses on your street and mine has an adult in it tonight who either has active addiction, who's in recovery from addiction, or who has sadly been excluded from that household because of their addictive disease. This is an incredibly common illness in America. There's about 30 million people with alcohol problems, 30 million. There's about 4 million people with opiate problems, about 2.5 million people with cocaine or stimulant problems, and about 2.5 to 3 million people with marijuana problems. And they often are the same people. When you see a person with an opiate use disorder, very often, almost always when I meet a person with heroin addiction or opioid addiction, almost always they had a pre-existing alcohol problem or marijuana problem or other substance use problem, and now they're passing through a period of life where opiates are their primary drug of addiction. So it's the same people who tend to move back and forth between these various substances. Addiction is a brain disease. It's a disease that affects the brain. And as I said, it affects the brain of somewhere between 1 in 8 and 1 in 10 Americans. So if everybody, and everyone doesn't, but if everyone in America decided to try to be a social drinker, about 1 out of 8 people would activate the disease of alcoholism. If you give opiates as pain medicines to everybody in America, about 1 in 8 will activate opiate addiction from exposure to the pain medicines. So it's about 1 in 8 have this brain disease. And this brain disease of addiction involves several key factors. And this is how you can figure out whether a person has a problem or not. The first key with addiction is people lose control over their use. They lose control over their use. So people who are social users of alcohol or other drugs never lose control over their use. But people with addictive disease, they repetitively lose control over their use, which results in problem behaviors in their life, bad behaviors. Then they have adverse consequences. Then they repent, and they apologize, and they beg for forgiveness, and they promise to everything they consider dear or holy in their lives that they're never going to do it again. And as long as they keep using, sooner or later they lose control again. They get out of control with their behaviors. They do stuff they wish they hadn't done. They feel remorseful later, and they go through this cycle of loss of control, bad behaviors, adverse consequences, feeling terrible about themselves, promising to make a change, and as long as they keep using some, they keep doing this cycle. When they stop, they crave the substance. So the key aspects of addictive disease and opiate addiction is intermittent loss of control, problematic behaviors, adverse consequences, remorse, promises, and then if they keep using, loss of control again and going back through that cycle. And when the substance is taken away, they crave the drug. And that's why people with addictive disease really require support and treatment. The key aspects approaching addictive disease are support and treatment. So who gets addiction? If 1 out of 8 Americans develops it, why do they get it and other people don't? We know a fair amount about that now. People who develop it, at least 50% of people who develop an alcohol or drug problem, at least half of them develop it because they inherited it. It's a fairly genetic familial disease. About half, between 50 and 60% of people who develop an alcohol or drug problem develop it because they've inherited it. It runs in the family. Just like other things run in the family. Brown eyes. At this stage of my life, gray hair. Used to be brown, trust me. But just like various traits run in families, addiction is a disease which is about 50% genetic. About 50% of people who get it because they inherited it. About 25% of people who develop addiction develop it because of experiences in their life. We call it environment. So it's about 50% nature or genetic, and it's about 25% nurture or things that happen in your life. And then the last 25% of people who get it, we can't figure out why they have it. It's bad luck. I don't know. It's just they wind up with it. But it's mostly genetic, partially environmental disease that affects the brain. And when it's active, it affects the behavior control part of the brain. And therefore, what we call the natural history, or the way that addiction marches through people's lives, is this way. It's exactly the opposite of most medical diseases. If you have a disease in your brain which results, when it's active, in problematic behaviors, the first part of your life where you absorb suffering is in your self-image and self-respect and sense of self-concept. So the first thing that happens to people with addiction as they begin to lose control is they begin to lose a sense of self-respect, a sense of self-concept, a sense of self-efficacy, and a sense of hope. So hopelessness is in the first phase of the disease of addiction. The second phase of addiction, of the disease of addiction, involves problems with close love relationships. The people in the life of a person with an addiction problem who absorb the second most damage from it. The person who gets the most damage is the one with addiction. The people who get the second most damage are close loved ones. Because there's a very narrow margin between us being our best as a parent or as a child or as an aunt or as an uncle or as a grandparent. A very narrow margin between us being our best and us doing poorly enough that the family says, "What the heck is wrong with dad or mom?" And so close love relationships are the second areas of life that absorb pain and suffering from the disease of addiction. The third domain is social relationships, because Americans tend to socialize with alcohol and other drugs. And so people lose control of their behavior in social areas. The fourth is financial. The fifth is legal. The sixth is work or school. Now, most Americans think you don't have a problem unless you've lost your job. But actually, it's the second to last thing to go is the job. The difference between doing your best at work and doing so badly that people say, "What the heck's wrong with you?" is generally pretty large. Whereas the difference between being your best in your family and doing so badly that your family members start saying what is wrong is very narrow. And so that's why the job or work is the second last to go, and physical is the last thing to go. So the natural history of addiction is loss of self-image, self-concept, self-efficacy, and hope. Second is loss of family. The third is loss of social relationships. Fourth is financial. Fifth is legal. Sixth is job. And seventh is physical. The body starts to go south. So if that's how addiction works, what's different about opiate addiction compared to alcoholism or cocaine addiction or marijuana addiction? The thing that's different about opiate addiction is if a person has an overdose on alcohol, they pass out, they have a blackout and don't remember what happened, and they sleep it off. If a person has an overdose on cocaine, they get paranoid and chest pain and go to the emergency room. If a person has an overdose on marijuana, they eat everything that's in the refrigerator and get a little paranoid. And if a person has an overdose on opiates, they die. Opiates suppress the brainstem. And when opiates depress the brainstem, a person slips from feeling warm and fuzzy and high to nodding, which is level 1 coma, to being asleep, which is level 2 coma, to being dead, which is level 3 coma. And it all happens while you're asleep. And so that's why the death rates have been so high with the opiate crisis. But other than that, opiate addiction first affects people's self-image, self-concept, and sense of self-worth and hope, and then their close love relationships, and then their social relationships, and then their money, and then their legal relationships, then their work or their school, and finally their physical health. It's the same story, just a different substance. It's just that if a person overdoses on opiates, as they say, opiates don't take prisoners. People die from opiate overdoses. They don't wake up the next morning. Or if they do wake up the next morning, they often have brain damage or other terrible problems. So how do we treat opiate addiction? And one of your future sessions is going to be mostly on treatment, so I'll be very brief about this. The way to treat any addiction is called sobriety. Sobriety and sobriety. If I forgot to mention it, the way to treat any addiction is sobriety. A person who has an opiate addiction problem needs to get off opiates, and they need to work a sobriety program in their life. A bio, sort of physical, psycho, counseling, social, 12-step, spiritual, family approach to sobriety. The best treatment for addiction is a bio, psycho, social, spiritual, family treatment approach. And so people need to get sober. A person who's trying to get sober from opiates can't keep drinking. They can't keep smoking pot. They can't keep snorting a little bit of Adderall or doing some cocaine or methamphetamine. They need to quit euphoria-producing drugs in general. The biggest risk for a person with any addiction of relapse is experimenting with one of the other addictive drugs, because it tends to either hook them itself or it tickles their cravings to go back to their previous drug of addiction. So they need sobriety. And when I think about sobriety, I think about a chair. I think about a four-legged chair. Everybody knows that a four-legged chair is the most stable chair you can sit in. And when I tell my patients who are thinking about working on sobriety, when I tell them how to put together a sobriety program, this is the program I tell them to put together. The first leg of the chair is counseling. And people need good quality counseling from licensed professional counselors. The second leg of the chair is support from the recovering community. And that usually works best if it's not only social support, but also spiritual support. The spirituality of the 12-step program is what helps to return a sense of hope to a person who lost hope in the earliest phase of the disease. They lost hope in themselves because they tried to control this and they couldn't. They lost hope in everything they knew. And it's essential to return hope to a person in early sobriety, and that involves a higher power. A person has tried everything they know and they've failed miserably to get sober. They need to believe that a power greater than themselves can help return their life to sanity. They must believe in something like that. It works best. And if I run into people who are atheists or who are non-believers, I tell them, well, you have to believe that something out there is greater than this disease. And so just keep an open mind about what that something is and start working with your counselor and working with the recovering community. So good counseling, involvement with the recovering community, typically 12-step programs and meetings. The third is a sober, supportive place to put your head on the pillow at night. You need a sober, supportive place to put your head on the pillow at night. It's very difficult to stay sober when you're living with people who are actively using, trying to sabotage you. And then the fourth thing can be medication. And I'll specifically mention one medication because it relates to this series that you all are talking about. And that's the Project Dawn program. The Project Dawn program is a program to help avoid overdoses. Naloxone is a drug that avoids overdoses. It blocks opiate overdoses. It wakes people up from the brink of death if you give them naloxone when they're in the middle of an overdose. It's essential for anyone who has a friend or family member who has an opiate problem to get a Project Dawn kit. It has naloxone in it. It has an instruction packet in it on how to use the naloxone. It's absolutely essential. What I tell my patients is I hope no one ever has a relapse. But if you do have a relapse, I want you to have a naloxone kit with you so that we can bring you back from death and take another swing at you in treatment to try to get you more sober this next time around. Having naloxone around is kind of like having house insurance. Nobody ever plans to have a house fire. But just in case your house light's on fire, everybody buys house insurance. And that's why it's so important to have naloxone. So medication, a safe, sober place to put your head on the pillow at night, active involvement in a 12-step recovering community, and good quality counseling are the four-legged stool of a good, stable sobriety program. And if you're missing any one of those legs, it's a less stable stool, and it can tip over if it gets pushed from the wrong direction. I think those are the major things I wanted to talk about in terms of opiate addiction here this evening. I know we'll have some time for questions a little bit later on. So let me stop here and turn things over to my dear colleague and good friend, Dr. Jim Psarras.
important part psychiatrically is that people need to be accurately diagnosed. Dr. Parran didn't talk about the number of misdiagnoses of substance abuse issues, and I'm not as obviously skilled as he has in that. I'm simply going to say that there are misdiagnoses in substance abuse issues. You need to have the right people that make the right diagnosis. And my mic's not working. Your mic's not on. Okay.
So just give him this.
Okay. Thank you. We were talking about accurate diagnoses, and I think that is so critical because there are people who come across, now Dr. Parran can make accurate diagnoses, but not everybody can. So people come in and say, well, geez, I'm not sure, or maybe you do, or maybe you don't, or maybe this is happening, or maybe that is happening, and the person walks away, or someone goes to a meeting and a very well-intended counselor in the meeting says, well, I'm not sure if you have something or if you don't have something. And there may be very honest answers. I'm not suggesting that people aren't giving honest answers. But one of the things you learn in medical school is that taking an accurate history and making an original diagnosis leads you to the proper treatment, leads you to take, if you see the symptomatology that Dr. Parran was talking about, you can make an accurate diagnosis. Well, that's also true in psychiatry. One of the things that we learn is that, and I'm not going to throw numbers out about how many people that I end up seeing that have opiate use disorders or alcohol use disorders have concomitant psychiatric disorders, but it's high. I have worked on a dual unit, which simply means that people have an opiate use or alcohol use disorder and a psychiatric disorder, usually depression, bipolar, anxiety disorder, personality disorder, or some combination of those things. And what I've learned through the years is if you only diagnose one of those accurately, either one of them accurately, and or only treat one of those accurately, you're missing half the boat. So if you look at the opiate use disorder and you don't treat the psychiatric part, it's going to be harder to get the person better. If somebody comes in and they have a psychiatric disorder and you only treat that and you fail to make the diagnosis accurately of the alcohol use disorder or the opiate disorder, you're going to miss that boat. And so the notion that it's a dual problem is really a very accurate sense. I also do consultations up on the detox units. We kind of used to do that just where you go up and see someone and then you do a consultation and make a recommendation. Now we've been able to move more in the direction of having a psychiatrist see the people more regularly, and it's amazing. I can just tell you empirically, not with statistics, the number of people that I walk up to and ask them if they've had a psychiatric history and do what I suggested earlier in the talk. You take an accurate history and you say, well, are you taking medication? No, but I used to take medication. Do you have depression? Well, I used to have depression. Are you in counseling? Well, I haven't been in counseling for a while. If you actually take the time to look at those things, you find out that they want to go back to counseling. They may want to start back on medication. They may want to get some help and help them with both sides of this issue. And I think that is where psychiatry and substance abuse and psychiatrists and AA have learned to come together. Years ago when I first started, and I don't want to date myself, psychiatry was over here and AA was over here. And each of them could tell the flaws in the other. But we decided to kind of learn to trust each other and to kind of work together so that, people can take psychiatric medications if they have substance abuse disorders, as long as they're taking the appropriate medications. One of the other issues that I was talking with Pastor about beforehand that I think it'd be hard to have this talk without talking about the stresses that are out is COVID. COVID stresses everybody. It stresses me, it stresses everyone here, everyone listening. It stresses my grandkids, my 6-year-old and my 9-year-old grandkids. They don't know what to do, and they're the sweetest kids around, but they've been locked up. People, if you didn't have an anxiety disorder before COVID, you do now. and I don't mean that diagnosed, but your anxiety went from here to here. If you didn't have depression because you're isolated and you haven't seen your friends and you haven't seen your families, or you had to go to a funeral like this, or look at what we're doing tonight. There's, only the people that need to be here. Well, that's not really how to do this talk. How to do this talk would be to have people sitting here. It has affected everything. And the point of that is that those stresses, the kind of environmental things that Dr. Parran was talking about, the 25 or maybe that other 50%, are severely affected by COVID and by the stresses of isolation and loneliness. Most of the time that I do the telepsychiatry, I spend at least half of that time trying to find some way of helping people that have pre-existing anxiety disorders figure out how to do it, because you can watch the governor every day and the nice lady who does the sign language that became a cultural hit, but they're still not exactly telling you. It's still left to your own interpretation. And what people will do with their own interpretation is that their underlying anxiety level will take over and start making decisions that may not be in their best interest. So they may stay home, they may not see people, they may do things. That's not necessarily leading people to opiate use or non-opiate use, but it is a stress that right now is an enormous stress across the country, across the world, and is just making everyone's life that much more difficult, which does lead to a lot of problems, including opiate use, alcohol use, and those kinds of things. So that's the psychiatric issue, the important part of medication. I'm going to bring up a very controversial topic that Dr. Parran has allowed me through the years to respectfully disagree with, just in terms of what to do. And that is that one of the, a lot of patients say, I use because I feel so badly, because I'm so depressed, because I'm so anxious. Okay, so what do you do when the treatment of one of those disorders, anxiety disorder, is something that you can abuse? Medicine doesn't have a lot of that. If you have heart disease or you have something else, usually, we're not going to not give you insulin or an antihypertensive because you might abuse it. And what if the better treatment sometimes is something that you can abuse? Well, that's a decision that has to be made by each individual practitioner, by each individual patient. But it's an honest issue, because anxiety disorders are very serious disorders. People don't think they are, but people miss as many days of work for anxiety disorders as they do for depression, which is a little known fact because you don't see it on television. You don't hear about anxiety disorders. You don't hear about panic, except that the number one reason that people go to the emergency room with chest pain is because they're having anxiety disorders and or panic attacks. So this is a big deal, and treatment of it is very everybody on benzos. I'm simply saying because they are addictive, and what Dr. Parran said is right. One has to be super careful, and sobriety and staying away from those things is the best treatment. But there are some difficult decisions that need to be made about those things sometimes, and I'm only trying to raise that to maybe anticipate some questions, because those kinds of things aren't talked about very often, and when they are talked about, you have a lot of different camps, and sometimes we have to just recognize that there are different perspectives about these things. The second part that I wanted to talk about has to do with a story. And the real important part of the story is not what happened to myself or to my family, but how it happened. Because one of the things that we have to work on is prevention. And everyone talked about this, education. And this story will show you how education, no matter how much they talk about it, that families just don't know about it. They don't know what to do about it, and it remains a very difficult problem. My 19-year-old, he was 19-year-old in 2004, youngest son used to argue bitterly with his mother about marijuana. He would say marijuana isn't addictive. She would say, yes, it can be. It's not on its own addictive, but it can be problematic, and it certainly can lead to other things. Yes, it does. No, it doesn't. and we go back and forth at the dinner table with that. Neither, we never got anywhere in those kinds of discussions, but at least we were trying to talk about it. And in January of 2004, we got a phone call from my son's best friend, and I'm going to tell you what happened that night because it highlights what Dr. Parran just got done talking about. My son didn't overdose per se on heroin. He naively tried it. It was the second time he had tried it. And I don't think that he took an inordinate amount, but somehow he was sensitive to it. So he got sick in some of the phases that Dr. Parran spoke about. And his friend, it was 4 or 5 in the morning, and he said, "What's going on?" And he was throwing up in the bathroom. And his friend called the drug dealer. At least he called somebody. He didn't call us. He didn't call his mother, who his friend was, she was like a second mother to him. So he knew he'd never get in trouble. He had lived with us because he had problems in his own house. He'd lived with us for a couple of months down in the basement. So he didn't make the phone call that would have changed our entire life. But what he did do is call the drug dealer. And what the drug dealer said was, let him sleep it off. Well, he's in heaven today, sleeping it off. He died that morning. And what happened after that is that in our house, we lived in Shaker, parents came to help us grieve and mourn. And what I heard through that whole week, in addition to my own grief, was how nobody knew anything about anything. And we never thought that marijuana would lead to something. We never thought there was a problem. We never thought that opiates existed in an upper middle class suburban community. And the more we found out about this, the more we realized how much education was missing. Everyone seemed so naive. We had seemed naive as well. And so when you talk about these kinds of things, when you talk about Narcan, if there was education that night, I probably wouldn't be sitting here. I might have been because of my knowing Carole, but my son would be alive, and it's just that simple. The difference between changing the entire course of an entire family and not is as simple as education, and helping people understand, helping parents understand, young kids understand that experimenting is not such a good idea, which is what Dr. Parran was talking about. And it starts, I don't want to overblame marijuana, but it often leads, it can lead, and it's kind of taken the wrong direction nowadays in my point of view and Dr. Parran's point of view with the legalization of marijuana. So that was one side of it. The other side of it is that I think we need to be tougher with drug dealers. This was a young man who lived in the area here, who happened to be, this was what he was doing. He was 20, 21, and the more we found out about him through the Shaker Heights police was that he was the drug dealer for, inclusive, Shaker Heights, Cleveland Heights, Orange, Chagrin Falls, Hudson, Hathaway Brown, University School, Hawken, and I may have missed one. Okay, so my wife and I decided to do several things. One of the things we decided to do was prosecute him. At the eulogy, so this is standing in front of pews and things is unfortunately too familiar to me. At the eulogy, one of my friends who lived down the street is a member of a very prominent law firm in town, and I spoke his name out and said, I think the cause of death for my son was that he was murdered. And a hush, it was already a hush there. A hush came over the entire church, and I said, what is the difference between some form of manslaughter, some form of murder, and prescribing, giving medicine for profit, because I'm sure that he got paid, without a license and not taking a history? Had a history been taken, we would have found out the person would have found out, and obviously wouldn't have known what to do with it, I'm not being naive, but would have found out that my son was in that 50%. There was, on my wife's side, a very strong family history of alcoholism, and that she was extremely sensitive to narcotics. So whenever she would have the most minor procedure, she would be the last person out. They'd kick us out of the recovery room because one dose of Percocet or one dose of morphine knocked her out. So how come these people aren't held accountable when they're giving medicine? You know, if you're going to make money on something, shouldn't there be some guidelines? Shouldn't there be some rules? Shouldn't there be something if you're going to take money from someone else and you're giving them something? We were successfully able to not prosecute because the prosecutor down in Cleveland thought that the investment in that case wasn't going to win. But for the time that we were prosecuting, we were going down there, we drove the drug dealer out of the state. He went to Florida for about 6 months and then came back. And out of that, we formed a foundation, which isn't important now, just to help education. We went to high schools, and you found out going to high schools. My wife would show scans that showed what the difference is of a brain of someone that's just a casual user of marijuana versus a normal brain. And we would talk to parents, and I would talk about this aspect, and she would talk about the biological and radiologic aspects. And what we were able to show and talk about to patient, you know, parents would come up afterwards and talk to us and say they were not aware of any the degree with which opiates were prevalent. So I'm going to wrap up a second here. I think in the education, one of the things that I talked about when I would go to the schools and the kids is that the people who are giving the advice about don't use drugs and don't use marijuana and that are not white, conservative, religiously right Republicans. Okay, these are professionals who are trying to say to you, listen, there is something going on with this, and be careful, and have the parents understand and the kids understand, so that we can begin to try to change the course that we have not been successful at changing, because it has turned from something that was just happened in Shaker Heights and kind of spotty areas into an epidemic. I know we need a question and answer time, so I'll leave that story as it is, but I think that illustrates the kinds of things that we've been trying to talk about tonight. Go ahead, Carole, you can come. Yeah. Go ahead.
Okay, well, we do have some questions. And so how I'm going to manage this, I can actually answer the first one. And before I do, I'm going to give a little bit more of an explanation on this naloxone kit. Because on September 12th, from 10 a.m. to 12 noon, the Metro Health van will be in our parking lot right here at First Baptist Church, and they will be distributing naloxone kits to anyone that shows up to get one. There are only 50 kits available to us, so this will be on a first-come, first-served basis. But these kits are also available through the Cuyahoga County Health Department, and then also through Metro Health, I believe the free clinic. Also, there are a variety of different places. But I just want to show you very briefly what is in the kit so that you have an understanding. This is what naloxone looks like in this form. It comes in many forms, but in the particular kit that we have that they'll be passing out, this is what it looks like, which is just a nasal inhaler. So anyone can actually administer to this to someone that's having an overdose, because it's basically just pushing on it up somebody's nostril. It doesn't matter which side, just so you push it up there. There is also a video in here with Dr. Joan Papp giving you a demonstration on how to use this medication for someone that is having an overdose. There's a face shield. There's gloves And there is also a fentanyl test strip. These are also available at a variety of different places. They're available through the free clinic. They're in every naloxone kit that is passed out, because if you're going to use drugs, you really need to test your drugs. All right? And the reason that we're saying that is because there is a lot of synthetic. You might think that you're buying Percocets or Vicodin on the street, but I'm telling you right now, you're not. You're buying fentanyl, because that's what's on the market today, is pressed pills that look like Vicodin, they look like Percocet, but they are in fact pressed fentanyl. So if you're looking for a naloxone kit, you can show up on September 12th to our parking lot, and you will find the Metro Health Project Dawn van in our parking lot distributing these kits. At which point, if they've run out, I'm sure there will be information for you on where you can get a kit. Okay, this one I think is going to be for Dr. Parran. And the question is, if I or a loved one is using opioids, are there signs to know if we are nearing an overdose?
I have, it's on here. I think this is on. If this is on. So, unfortunately, as I said, when a person uses an opiate, they get some pain relief, they get a little bit sleepy. That's called the nod. They sort of get a little bit noddy or a little bit sleepy. Unfortunately, that's the goal that many people have when they're trying to get high with opiates. They're trying to nod. But as I mentioned, the nod, when the person is sort of nodding out and sleepy and slurred in their speech and lethargic, that's level 1 coma. If they then fall asleep because the drug is hitting them even harder, then they're asleep. That's level 2 coma. And they often start snoring really loudly. And then they slip into death. And so, unfortunately, if a person's using opiates, be sure you have naloxone available. Encourage them every day that there's a better way and to go get treatment. And worry, because every time they use, if they start to nod and then they fall asleep and start to snore, you better give them naloxone and call 911, because they could well be on the verge of the next step, which is death.
Okay, the next question actually is for our pastor, for Pastor Kregg. And the audience is asking what specific ways the church can support both psychiatry and recovery. And that's actually the perfect time to answer this question, because I'm actually going to be turning it over to Kregg to end this series for us and tell you about next week. We hope that you can join us next week, and I'm going to turn this over to Pastor Kregg and let him answer this question.
Thank you so much for being part of this very important conversation. My name is Craig Burris. I'm the senior pastor here at First Baptist Church, and I do thank you so much for being part of this. I want to remind everyone before I answer that is that we will be joining our second seminar next Saturday, this coming Saturday, which is September the 5th at 7 o'clock. So just tune in and join us. Also, to remind you, before I forget, and that is click the link that is associated with the webcast here, and there you'll be given some information about registration and some important things that will help us, and I appreciate that. The next seminar that I'm going to be a part of, as well as Ship Collins, who is our youth minister here at First Baptist Greater Cleveland, is the importance of community support. I appreciate the comments about the importance of spirituality as a component towards helping those that are going through addictions. As a pastor, I've also, on many different levels, seen individuals who have struggled. And when hope is lost, it's a downward spiral. Depression, shame, You feel like you've let everyone down, you've let yourself down. But God is there for you. He loves you, created you, and has a plan and purpose in your life. And so community support, the church, family, friends, those that are able to encourage you and regain that important sense of hope is a very important part of that journey that we're all on. And we stumble, we fall, that's part of our human nature, but also in faith we have the opportunity to think about redemption, forgiveness, new beginnings. And so if you're struggling, you're not alone, and there are people there that love you and want to care for you and help you. So join us again next week at 7 o'clock as we have that conversation. I've been asked to have a closing word of prayer, so join me, would you please? Our Father God, thank you for this evening. Lord, the testimonies and the information is so valuable. And Father, if it just makes a difference in that one person's life, it's all worth it. And so whoever it is that's watching this right now, I pray for them. I pray you'll guide them, strengthen, be with them. Let them seek help. Let them find professionals that they can talk to. Let them begin a process that they can grow towards health and freedom. And I pray that you'll guide us, and thank you for being there with us. And we pray these things in your holy name. Amen.